welcome to AETCM, the emergency medicine channel. So we've got a 21-year-old male who presented with a 3-day history of right flank pain, chills, and cough with blood-tinged sputum. So for the history, the patient had a history of lower back pain for about 7 days, for which he had taken just analgesics, which he had taken for 3 days, and then he developed right-sided flank pain, chills, and rigors associated with hematuria and multiple episodes of vomiting.
Okay.
He went to
fever and chills and rigors. What are the indications for NSAIDs? Should we recommend NSAID or not? There are a lot of doctors, they give NSAIDs. We cannot tell that is wrong. What is the problem of giving NSAID in a patient who is having fever, chills, rigors, infections? What are the newer guidelines? What is the newer guideline? What are the problems? Decrease the? So it always reduces your immunity. When you are taking steroids or steroid sparing agents, it is going to reduce your immunity. So now it is found that antibiotics, suppose you require antibiotics, their actions will be reduced because your natural immunity is reduced. Second important thing is most of these patients can have kidney failure. This will aggravate kidney failure, especially aceclofenac. Third one is they can have thrombocytopenia. That also will be aggravated by your NSAID. So NSAIDs are not a good choice in acute fever, chills, rigors. They may relieve the symptoms, but they can sometimes create a lot of issues. You can safely give paracetamol. That is okay. So that will be better.
So he went to a different hospital where a URE showed pus cells of 22 to 25. Albumin was 1+, and bacteria and RBCs were not present.
Okay.
So he had taken symptomatic management.
Is it all patients who is having pus cells in urine is UTI?
Not necessarily.
Okay, not necessarily. They can have a lot of other issues. Because of that issue, they can have pus cell-like cells in the urine. Okay, like epithelial cells, especially in female patients. But male patient, if you are seeing pus cells, there is a high chance for kidney involvement, urinary tract infection or kidney involvement. Okay.
Yeah.
What type of cells you get in drug-induced nephropathy? What type of cells are common in drug-induced nephropathy? Cells are there, no? Neutrophils, lymphocytes, eosinophils. What type of cells are common in drug-induced nephropathy? Eosinophils. So you have to look for eosinophils then. Okay.
So he was also started on antibiotics. So he took ceftriaxone injection, 1 gram, just one dose. Same day he developed on and off cough with expectoration of sputum mixed with blood. He had chest discomfort, breathlessness that worsened with exertion. Then he was taken to a different hospital where an ECG was done, which showed sinus tachycardia with T-wave inversion in 2, 3, AVL, V5 and V6, and tropi showed insignificant raise. On routine bloods, his total count was 11,720, platelets were low at 90,000, hemoglobin was 10.5, CRP was 187, creatinine was 1.6, urea 47, albumin 2.9, and SGOT, SGPT was 48 by 57. CT of the chest was also done, which reported bilateral diffuse ground glass opacities with patchy consolidation and intralobular septal thickening. Probability of diffuse alveolar hemorrhage cannot be excluded was also mentioned.
So when you have a patient who is having suspected tropical fever like malaria, leptospirosis, dengue fever, alveolar hemorrhage is an important problem. Okay. The prognosis in that type of patients will be very, very bad, especially in leptospirosis. If the patient develops alveolar hemorrhage, then their prognosis is very bad. Okay. Fortunately, this patient is completely recovered, but many patients will end up in complications, ventilation, then all these things. Okay. So we have to be very careful.
In view of the diffuse alveolar hemorrhage, the patient was started on high dose of IV steroids.
Okay.
So an injection of methylprednisolone 1 gram was given, and IV antibiotics. So injection of doxycycline and ceftriaxone was given.
Okay.
Then the patient developed respiratory distress, therefore was shifted here.
Okay.
On further history, there was no past medical history of note, no family history, no drug allergies, and he was not taking any other medications.
Okay.
And
but he had taken NSAIDs.
Yeah.
So
that he'd taken right before.
Okay, so that is an important history. NSAIDs in fever patient, especially leptospira or severe dengue fever, malaria, all these things are complicated things. Okay, so we have to keep that diagnosis separately, NSAID induced. Sometimes leptospira may be innocent here. The drug may be producing all these complications. Okay.
And on social history, he was not a smoker.
Okay.
Just systemic examination, initial 10-second assessment, he was conscious and oriented. Airway was appeared patent with no secretions. Breathing wise, air entry was bilateral and equal, and there were normal vesicular breath sounds.
Okay.
Respirate was 36, and SpO2 was 99% on 50% FiO2 on NIV.
Okay.
Blood pressure was 110/80, and his pulse rate was 76. GCS was 15, so E4, B5, and 6, and pupils were 2 millimeters, bilaterally equal and reactive.
Okay.
And exposure-wise, he was afebrile.
Okay.
Local examination, there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edemas. And systemic examination was there was nothing of note.
Okay.
Then the plan was, because he was already starting an NIV, was to continue his NIV and monitor him and continue the antibiotics and the steroids that he was taking. So in ICU, we had kept him on BiPAP FiO2 of 40%, and which he slowly weaned off. And a repeat ECG showed sinus bradycardia.
Tell me what are the indications for BiPAP in ER? You tell contraindication, that will be better. Any breathlessness with some contraindications. What are the contraindications? Overall, you don't use BiPAP. Pneumothorax, we don't use. Second thing is?
Trauma. If they have
Trauma
chest.
with facial injury, we may not use. Chest injury, we can use.
Okay.
Pneumothorax is one, facial injury is another one. Hemoptysis, abdomen distension, okay, or severe vomiting. Then low GCS. If the patient is having full consciousness, there is no facial injury, there is no pneumothorax, you can definitely start BiPAP or CPAP. That depends on the scenario. You select BiPAP mode or CPAP. You can give in all patients. That is the safest thing nowadays. Okay, what is HFNC? Okay, so that will, this has got some claustrophobic feeling, this mask. So many patients may not like it. That type of patients, if it is a type 1 respiratory failure, you can surely go for HFNC.
Okay. So a repeat ECG showed sinus bradycardia, which was done here.
Okay.
And there was...
So what do you think that sinus bradycardia is due to?
There was myocardial...
okay, involvement, especially SA node involvement may be there.
Yeah. And he had normocytic normochromic anemia with neutrophilic leukocytosis and mild thrombocytopenia.
Okay.
A leptospira PCR was done, which showed no DNA detected.
Okay.
But leptospira IgM ELISA showed positive.
Okay.
Dengue test was also done, which was negative. And a screening echo was done, which did not show any clot, vegetation, and good LV function.
You have to see pericardial effusion when you are doing echo. You should have some aim, no, to do when you are doing echo. One is pericardial effusion. The most common problem in all these tropical fevers is pericardial effusion. Then you can get global hypokinesia. These are two things we observe in most of the patients. Okay, valvular disease and all very rare in tropical fevers, but infective endocarditis you get. Okay.
Then a test for other antibodies like D-ANCA, C-ANCA, C3, C4 were all negative.
So when somebody is having no fever with pulmonary alveolar hemorrhage, we have to rule out good Pasteur syndrome with renal involvement. That's why they have sent from outside. They have sent all the investigations.
So he was continued on these antibiotics. He improved. The chest X-ray done here showed bilateral diffuse patchy infiltrates, which improved over the 4 days, and then he was discharged from the ICU.
Only thing is whether steroid should be given or not in this patient. That is the only question. There are some data shows early steroids may be helpful. High dose early steroids may be helpful in pulmonary alveolar hemorrhage. Okay. The same thing, it can be helpful in pulmonary alveolar hemorrhage due to good Pasteur syndrome. But we don't have any evidence for good Pasteur syndrome in this patient. All antibodies are negative and patient has improved. We have stopped steroid immediately. Even then, patient has not deteriorated. That rules out a immunological condition. It's only an infectious condition.
So just leptospirosis is a zoonotic bacterial infection. It's caused by Leptospira intrudens. It is a thin motile spiral-shaped spirochete.
Okay.
In pathophysiologically, it has like this biphasic process where the first phase is leptospiremic phase in the first week, and then it is immune phase.
Okay.
So the immune phase is the most dangerous phase because that's when the antibodies are formed within the
Okay.
body. Clinically, the anecteric leptospirosis phase is most commonly seen in 90% of the patients,
Okay.
and only 10% actually follow through and become
Okay.
icteric leptospirosis. So in the anecteric phases, the patient would have flu-like symptoms, sudden high-grade fever, rigors, severe myalgia, headache, and conjunctival suffusion, which is pathognomonic, but it is not always seen. It can be transient as well. Patient might have abdominal pain, nausea, vomiting, transient rash, and it may mimic influenza, dengue, or other viral infections. Icteric phase, the patient might develop Weil's disease or
Weil
Weil
syndrome.
syndrome, which is jaundice, renal failure, hemorrhagic diathesis.
What is a syndrome?
Weil's syndrome.
Syndrome means what?
Oh,
Syndrome. So multiple symptoms or signs in the same disease. So that is syndrome. So most of the time you get partial syndromes. Okay, don't think that whatever is given in books you can see in the patients. You may get a partial syndrome. Suppose a Leptospirosis syndrome means all organs are involved. In some patients you can see only kidneys are involved. Some patients kidney and liver is involved. Some patient kidney, liver, brain is involved. So syndrome means everything is involved, but many patients what we see is partly involved. Okay.
So it is transmitted to humans through direct or indirect contact to urine of an animal, most commonly rodents like rats,
Okay.
but also cat, dogs, and pigs can also be involved. And the bacteria enters the human system through like skin abrasion, conjunctive, or other mucous membranes.
Okay.
So when we talk about the icteric leptospirosis, different organs can be involved, and whichever organ is involved, that kind of symptoms you would see.
Okay.
So if it's renal issues like AKI can be present, so patient can have oliguria, rising urea and creatinine. Hemorrhagic manifestations can be epistaxis, petechiae, GI bleeding, pulmonary hemorrhage and things. And pulmonary involvement, which was seen in this patient, would lead to leptospiral pulmonary hemorrhage syndrome, which leads to hypoxia, ARDS, and it has high mortality rate.
Okay.
Investigation-wise, urine dark field microscopy.
ARDS is different. Pulmonary hemorrhage is different. ARDS is mechanism is totally different. Pulmonary hemorrhage is actually bleed. Okay, that is more dangerous than ARDS. ARDS itself is dangerous. Bleed is more dangerous. Okay.
Investigation and diagnosis-wise, urine dark field microscopy of field urine sample demonstrates live spirochetes. So this can be done in the initial stages,
Okay.
and then PCR can also detect leptospiral DNA in early stages.
Okay.
But after that, we have to do like serology of like Leptospirem IgM ELISA,
Okay.
which is more specific. CBC will show elevated white cell count and low platelets, and serum creatinine can be elevated if there's renal failure. LFTs can show mild elevation as well. Modified Fain's criteria can be used clinically for making the diagnosis. Treatment-wise, we'd start with supportive management and then give antimicrobial treatment would be antibiotics.
Okay.
So doxycycline is first line here, but any antibiotic can work with
Okay.
Leptospira.
Okay.
Then if it's really bad, then we can give IV antibiotics as well.
Okay.
Studies have shown that corticosteroids, that's IV methylprednisolone, will have good prognosis if given early stages.
Early stages.
Yeah, it will decrease the mortality for
Okay.
patients, especially with pulmonary involvement.
Okay.
Prevention-wise, chemoprophylaxis can be given to people who are like more likely to be exposed to Leptospira. So workers in sewage, workers
Okay.
and people come under that category. So doxycycline 200 mg once weekly can be given.
Okay.
Or even if there are floods,
Okay.
then people in that population can be given.
Okay.
Animal control, environmental measures like sanitation is
Okay.
also important.
So that things are not possible in our country. We have to give only doxycycline whenever you are at risk. Okay, whenever patients are at risk, we have to advise them to take doxycycline. That is the best way of preventing leptospirosis, because one dose of drug is enough to kill all the bacteria in your body, all the spirochetes in your body. One dose is enough. Whenever you have suspicion, immediately start doxycycline. Okay, otherwise the problem is this patient may go to Weil syndrome phase, then drugs will not act because it's an antibody phase. Where the initial phase you can try all the antibiotics. Later phase, like you told, steroids may be helpful. That not in all patients. Okay, thank you.